So good morning, everybody. Thank you so much for tuning in to part 2 of our Living with Dementia Virtual Caregiver Workshop Series. My name is Candace Christensen, and I am the coordinator for the Caregiver Coalition of Northeast Florida, and we are so happy to have you. So before we dive in, I have a couple things to cover. One is that we have a short message from 2 of our fantastic sponsors this year. I'm going to go ahead and play that short video really quick.
How's everybody doing?
Hey, you guys.
Hi. It's time to lean on each other.
All of you guys, so much great support.
And laugh with each other.
Cheers.
Let's do it together with caregiving chats and more. Come find us at aarp.org/near you.
My wife, I call her a drill sergeant. She gave me the inspiration to build myself up. I need to go on dialysis. Florida Blues, they gave my wife good information. What I ate, how she cooked, and everything. In fact, if I go to the store and buy something today, she'll get it and read it and say, you can't have this. That's why I think I'm where I'm at today.
So we have several generous sponsors this year, including our 2021 Gold sponsors, Florida Blue and Community Hospice and Palliative Care, and our renewing Silver sponsor, AARP. So on behalf of the Caregiver Coalition, we thank you and we so appreciate your generosity and dedication to caregiving. A couple more
How's everybody?
Super quick things. A few housekeeping items. The session is being recorded and it's posted to our YouTube channel and our website. So all cameras and microphones, except for those of our speakers, are going to be turned off. And we just ask that you remain muted for the duration of the session. If you do have any questions during the presentations, you can type them into the chat box and we'll make sure they get answered when we reach that Q&A session in the latter half of the workshop. At the end of the session today, we're going to be holding a short poll on what you liked and what you didn't like about the session. And that just helps us continue to improve them throughout the year. Everyone who fills out the survey will be eligible to win a $25 Amazon gift card. We reach out to the winner by email after the session. And then lastly, in case we run into technical difficulties, please be patient. We're going to resolve them as quickly as possible. So with that, we are going to get started. I'm a couple minutes ahead of our schedule. So like I said, we have a great program today, and starting us out is Doug Schilling. He manages the Professional Development Department with Community Hospice and Palliative Care. Doug has been with Community Hospice since 2006, and he's served in some impressive roles, including manager of the Advanced Care Planning Department, clinical educator in the Professional Development Department, and hospital admission manager. Doug, thank you so much for sharing your time with us. I'm going to go ahead and turn it over to you.
Great, thank you very much. Good morning, everybody. So great to be here. Been with Community Hospice, as you heard, 15 years. I'm a licensed clinical social worker by training and education. But one of the reasons I have always had an interest in talking about and working with folks related to the topic of dementia is that about 8 months before I started here 15 years ago, my mom actually died with a dementia diagnosis, vascular dementia. And so I've been on the end of being a family member and caregiver as well. I think that brings an important component to educating and working and talking with people about this whole topic. I will tell you, I will warn you that this presentation that I'm using as the basis for this was originally a full 1-hour presentation. I've tried to cut and hack as much as I possibly could and still make it meaningful and useful. But I may still have more than I should. So I might be going through some slides relatively quickly. Candace, next slide, please. So just a reminder, what a lot of you may already know and be aware of, that dementia is in fact an umbrella kind of term, lots of different causes for dementia, lots of different types of dementia. We're not going to really get down into the weeds about all of that. Next slide, please. Certainly, The one that we hear the most about and we talk most about and we know most about is, of course, Alzheimer's. That's because Alzheimer's represents, roughly somewhere 65, 70, 75% of the formal diagnosis that people have. Some of these statistics are a few years old, and Dr. Robinson may be able to update them a little bit. But so we're talking somewhere between probably 5 and 6 million people that are living with Alzheimer's at the time, moving up in the ranks of it being one of the leading causes of death in the United States. Obviously, we're living longer. The longer we live, the more likely there's a possibility that we'll develop Alzheimer's. And interestingly, 64 to or so percent of folks who are living in long-term care facility as a residents have Alzheimer's. Slide, please. So certainly we do an awful lot of training of our staff, since a good, portion of our patient population at any given time, 1,250 or so we're taking care of today, have a dementia diagnosis. And certainly some of what we end up getting questions about, especially from family members and caregivers, because if they start to think or see some signs in themselves about memory problems or whatever, they start asking us questions. Am I developing this as well? And so it comes some of the slides that we try to make sure that we are presenting to people is sort of the difference between normal aging and Alzheimer's. And the next two slides sort of are that. For me, the metaphor that works when we think about dementia is that, our brains are our computers. They are our central processing units, and everything we think, do, remember, experience, all of our senses, all of our movement, all run by our computer. And so for me, especially as I am myself aging, the metaphor that works for me is, as I've gotten older, I sort of think of my computer as Windows 7, and and that Windows 10 is now actually the computer that people who are younger than me have. So yes, are our computers slowing down a little bit? Do they have a little less power? Do they have a little less memory? Is it harder sometimes to get them to do what they need to do? Yes, but the difference between normal aging and having, sort of a slower, older computer and Alzheimer's and other dementias is that the damage is not permanent, and typically, over time is something we can't remember, we get a cue and it helps bring things back. So slower, a little more difficult to work with, but it's not that the damage is gone and permanent and progressive. And so next slide, really these two slides kind of talk about and show that difference in the kind of areas that can be affected by dementia. That can also be sort of a little bit affected simply by aging. But bottom line really is that the dementia, the progressive nature of the damage that's happening, in our brains and our computers, sort of means that the problems are only going to get worse, not going to get better, and really things memory no longer exist, as opposed to simply it's a little harder to get to it and retrieve it. Next slide, please, Candace. So just without getting too much into the weeds of the bio, neurology of all of this, I think this slide helps people understand a little, some things in a way that could be helpful. And we've shown you the contrast between a brain on the bottom affected by Alzheimer's and one that's not on the top, and sort of circled areas in terms of what parts of our brain certain things happen. And when you compare the two, you can really see why. For example, there are big changes in that section of our brain that is our sensory strip and our motor strip, and where our senses are affected there, whereas certain areas like the automatic speech area, which, by the way, is also where our speech related to expletives and cursing and swearing takes place, which is why it's not unusual, for example, for us to see patients with dementia who are still really very good verbally at the swearing and cursing part of things, even when they might have serious damage about not automatic sort of speech. And I know my mom, who I never heard say a curse word her entire life, suddenly was swearing like a sailor at some point during the course of her dementia. And, you know, it's in that formal language and speech center that there are also huge changes. And that's why we may see somebody with problems with speech, except when it comes to certain kinds of them. Next slide, please. Important for us, as we're going to be heading quickly here into the idea of some things that we can do that might be helpful suggestions as memory aids for people. To keep in mind that also not unusual with dementia for there to be significant visual changes over time, which of course, you know, is a reminder to us to make sure we're in front of people and we're right in their immediate visual field while we're working with them and talking with them and interacting with them and caring with them. Next slide, please. Interestingly enough, there's a lot of research out there to suggest that things like reading and being able to interpret and understand pictures continues to be useful to dementia patients, even after perhaps their speech problems have become really very evident. And that's why you're going to see we're focusing on things like pictures and reading and writing notes or writing words as ways to assist people with their memory. Reading tends to be an overlearned skill that then ends up being maintained even after the ability to produce verbal components of things in patients with dementia. Next slide, please. So really, when it comes to being a caregiver with somebody with dementia, one of the biggest things that we hear about, of course, is how hard it is to communicate or how much caregivers think that they're not understanding or that their loved ones aren't understanding and how difficult that can be. And so, of course, you know, really the idea here is about trying to enhance different ways of being able to communicate with our loved ones with dementia. And so just some, you know, general ideas. We know one of the things we're most acutely aware of when it comes to dementia problems, especially Alzheimer's, is memory. And sometimes just being reminded that the best way we can communicate with people with dementia is to be able to live where they're living in terms of what is still there in their memory. And so things like correcting them about recent memory things that they're going to struggle with isn't really going to be useful, as opposed to validating and accepting and being able to put ourselves in that place of living where they're living as far as their memory. I noticed very clearly and specifically with my mom, for example, where her memory line kept moving back and back, and what she had a memory of kept getting older and older. So that at one point, you know, talking about where she lived, she told me, you know, Bakerton, Pennsylvania, and she'd have moved away from there in 1947. So rather than correcting her in terms of saying, no, Mom, you don't live there anymore, you now live in Clearwater, Florida, you know, it wouldn't make any sense to do that. And I had to sort of reorient my communication style in terms of being able to, you know, focus on the memories that she still did have and were still a part of her experience and her ability to relate to and talk about. And of course, you know, reassuring them and doing, you know, communicating in a calm, reassuring kind of way. Very important part of being able to communicate with folks. And if you don't, take away anything else, please also remember what we really try to drill home to all of our folks who are working with dementia patients. Behavior is communication. And the more we can tune ourselves into trying to figure out what this or that particular behavior that's going on with our loved one that we're providing care for is trying to communicate and understand that, the better. We hear things like, she's really challenging when I'm trying to give her a bath or whatever. Behavior is communication. Is she saying the water is too cold through her reluctance to be bathed? Is she saying she's in pain, she's uncomfortable, she needs to go to the bathroom? So the more we can remember that behavior is communication, and our job as caregivers, regardless of whether that's professional or personal, has to do with trying to figure out what that communication is about. Next slide, please. So again, be aware of the fact that dementia patients' visual fields are closing in, that we don't want to come up behind them and speak loudly to them without their knowing that we're there, for example. So make that visual connection first. Get at their level in whatever way that's possible. Make good eye contact. Be right there in front of them as we're communicating with them. Next slide, please. And then, engaging with them in a verbal way. Even though you may feel like it seems as though mom, dad, whoever I'm providing care for, doesn't sometimes understand that language, hearing your voice, a familiar voice that's calm and reassuring, it makes a connection that is important when we're going to be doing things with them and involved with them. Keep things simple, keep things direct, keep things black and white and cut and dry, because their ability to process abstract information or metaphorical information has been damaged. Slide. And then a physical connection, so important in terms of it being an acknowledgement of I'm here and I'm here for you and I'm here with you. We suggest, for example, the hand over hand kind of position there in terms of it being a supportive, reassuring thing. You're going to know your loved one better than anybody. So if a hand on the shoulder or around the shoulder is going to be something that is reassuring and relaxing and comforting to them, then certainly that. We created this presentation with also non-professional, but non-family and personal caregivers in mind. And so we have some suggestions based on that in here. Next slide, please. And of course, that emotional connection in lots of different ways. And certainly people read our body language, our facial expressions as part of the emotional connection that we make with them. But also, it's a reminder to share something of ourselves, even if it's just a simple kind of thing. Because again, people are going to at all different levels of their of the disruption of their activity of daily living. And we know with dementia also that there are some really good days where a lot more, seems to be making the connection and getting in there. And so since you never really know, I say do it, and do any of these things that we're talking about early and often. Don't think to yourself, well, most of the time he or she doesn't know what's going on or doesn't know who I am, because you just really never know. So do it anyway. That's always my suggestion about things. Next slide, please. And then finally, after you've tried to make those connections is when you can move to something like an activity. And we're going to talk about a suggestion for an activity that you can do in the creation of memory aids. Next slide, please. And so again, we're suggesting things like pictures and little statements and words that can be a part of a book or can be part of creating an activity. Don't forget again to remember where they're living in terms of their memory, in terms of what you use for that. Next slide, please. Pictures of loved ones, family members, always a great component to have as part of a memory aid kind of project or book. And again, names written underneath the name, the picture of people can be particularly helpful. Next slide, please. Now, when it comes to family member caregivers and those kind of folks that we're most likely to be having in our audience today, it's not like you need to be finding out information about them. You know this person. Although I will tell you that for my mom, for example, when we were doing some of these things, asking some questions from her sisters and her brother about certain experiences from early on in their childhood and their lives was helpful, because we included some of that, because we knew at that point that's where her memory existed, was from those periods of time. And so actually asking for some stories and some specific things from when they were all children was really helpful stuff. And we didn't necessarily know as much about that as we wanted to be able to create some of these memory aids. Next slide, please. And again, sort of getting stuff together to be able to make a little book, to be able to laminate it, put it in, create pictures, sayings, phrases, words, any of those sorts of things that can trigger a memory and help create an opportunity for interaction and a communication, can just really be a great little activity to be involved in, and pull out on a frequent sort of basis. Not a bad idea. Maybe even every day you find 5 minutes to go through some of these kind of things as a way to maintain that connection with somebody and help them to have the opportunity to be living where they're living in terms of their memory, that kind of stuff. Next slide, please. And keep in mind the strengths and abilities that your loved one, the person you're providing care for, still does have. And don't forget to remind yourself, down deep inside them, even when they may have trouble with their memory of who we are and what's going on around them, there's still people who are capable of caring and loving and emotionally reacting to us in positive ways. Next slide, please. Again, any of these sorts of things that we can do on a regular basis with people within the schedule that we have to try to maintain to be a caregiver can be useful. And for some folks, what they really respond to are things, pictures, sayings that can be related to what their career might have been and things that they spent a lot of their life doing from that standpoint. So that's why we say, work-related activities. Next slide, please. Music is absolutely fabulous with dementia patients. And again, part of that is because the parts of their brain that might be affected last by the disease progression and is still maintained has to do with music and rhythm, and that part of our brain that processes that. I know for my mom, for example, who, if she was still alive, would be about 96 years old. She was a big band era person, and so playing music from the big band era was just absolutely fabulous for her. And that's why, for example, we say, think about music that comes from their sort of golden age of music, those ages between 18 and 25. Getting them to sing along, you will find that some dementia patients who have a really hard time communicating or generating words can sing and know every word of particular songs. And they don't have any problem whatsoever generating and retrieving that. Next slide, please. Again, anything that gives them the opportunity to interact and communicate. And I know my mother-in-law, for example, who's in the very early stages, loves to color, and it just gives her something to do. She feels very creative. She feels like she's doing something positive, and it makes her feel really good. Next slide, please. So bottom line, again, we've got to be comfortable entering their world and living where they are living, encourage communication and interaction and reminiscing that are related to those things. You know, go online, try to find some pictures of products or things that may have been popular during the childhood of that person that don't longer exist. Make that a part of the collection of things you have in your memory age. You know, if hula hoops were the big thing then, you know, a picture of a hula hoop. Or, you know, products or things that were common that people knew about. Make that a part of it, because again, that's acknowledging and validating the part of their memory that they still have and can connect with and relate to. Look for opportunities to create, you know, successful experiences. That's a good place to stop. I've probably also run over my time. And again, remember, very important, all behavior is communication. Let's work at trying to figure out what a certain behavior is trying to communicate. Thanks.
Thank you so much, Doug. I know that was a lot of information in a short amount of time. So to everyone that's joining us, we are going to have these slides available after the presentation. I'll send them out to you. But thank you so much, Doug. We really appreciate it. A lot of really great information. So next, we're going to have Dr. Maisha Robinson. She's from Mayo Clinic's Alzheimer's Disease Research Center. Dr. Robinson, I'm going to share a little bit about you while I stop my screen share and let you pull your presentation up. So Dr. Robinson earned her medical degree from Tufts University, and she moved on to complete her residency training at the Mayo Clinic in Rochester, Minnesota. She's currently an assistant professor of neurology at Mayo. And she holds a joint appointment in the departments of neurology and family medicine. She established a neuropalliative care program at Mayo Clinic and currently serves as the medical director of palliative medicine and is the program director for the Palliative Medicine Fellowship. Dr. Robinson, the floor is all yours.
You're muted. Oh no.
There you go.
So, you know, I hear this all the time. I was thinking about palliative care for my loved one, but I don't quite think we're there yet. Or I hear people say, I almost asked my father's doctor about getting palliative care involved, but then he might think that I think he's dying. So I want to spend a little bit of time today talking about maximizing quality of life in dementia using a palliative approach. So when I think about palliative medicine, I think about a specialty of medicine that aims to really recognize, prevent, and alleviate suffering of all forms, physical, psychological, spiritual. And we're not only thinking about our patients, but also their loved ones and their family members. We're taking an interdisciplinary approach to managing that person, the whole person and the whole family. We're thinking about symptom management. We're thinking about how nutritional status may be impacted. We're even thinking about how finances may be impacted by what's going on. And palliative care is appropriate at any age and at any stage, independent of life expectancy. So it used to be that people thought, hurry, 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 call palliative care when somebody was about to die. But what we know now, there's a role for palliative care at the actual time of diagnosis of a serious or advanced medical condition. And certainly the palliative needs will increase throughout the course of disease. But what you'll see is that even at the time of death, there's still a role for palliative care through hospice care. And so I like to say that palliative care is kind of this umbrella term. It's a specialty that tries to focus on improving quality of life for people that have a serious or advanced medical condition. Under that umbrella is hospice care, which is palliative care, but specifically for people who have a life expectancy of 6 months or less. So while all hospice care is palliative care, certainly not all palliative care, what I do is hospice care. So palliative care is actually one of the fastest growing trends in healthcare. I often ask people, why do you think that might be? And people say to me, well, because we're living longer. Exactly. That's one of the reasons. People are living longer and therefore they're having more conditions which would lend themselves to involvement of palliative medicine. But also word is getting out. People are realizing there is value in getting palliative care involved, not only for the person with the medical condition, but also for the family members, caregivers, and other loved ones. You know, this graph shows just the rise in palliative care in US hospitals from 2000 to 2015. Now, we don't have the most up-to-date data, but what we know is that even in 2015, most hospitals with greater than 50 beds then had a palliative care service. So that talks about the value of palliative care, not only to our patients and family members, but institutions are recognizing it as well. This is not just a problem in Jacksonville, Florida. This is not just something that we're talking about in Northeast Florida, not just something in the southern part of the United States or even in the United States only. This is an international issue. Everybody is trying to figure out, how do we improve quality of life for people that have serious or advanced medical conditions such as dementia? Now, this is the same slide that I just showed you a couple slides ago in Russian. So when we think about a palliative approach to care, I'll tell you that every clinician is doing some degree of palliative medicine if they're caring for people that have dementia, whether they're a neurologist, a geriatrician, an internist, a family medicine physician, an advanced practice provider, a nurse. Anybody taking care of people with dementia is providing some degree of palliative care. Most people are providing what we call primary palliative care. That is the basic management of pain and symptoms, having general discussions about big picture and goals of care. Talking about suffering and ways to alleviate that, and talking about code status that has to do with, the chest compressions and CPR. But what we know is that there's a shortage of people who specifically focus on palliative care, like what I do, and therefore we need people's primary care physicians and their primary care providers to really be providing palliative care. But in some situations, the issues are complex. And some people can benefit from specialty palliative care, for instance, what I do in my clinic and with my team. So sometimes there are refractory symptoms that are hard to manage or very challenging to manage. Sometimes there are conflicts within families about the best next step in care for a loved one. Sometimes the medical teams don't all agree on the next best step, and palliative care can kind of help talk through some of those options and figure out what may be in the best interest of our patients. And so specialty palliative care is available for some of the more complex and challenging situations. So people want to know always, what do you actually do when you're in a palliative care consult? Are we just holding hands and hugging everybody and singing Kumbaya, maybe pre-pandemic? But what we talk about are really these 8 domains of palliative care. The first is structure and process. So we ask people, what do you understand about your medical condition? We want to make sure that our patients and family members have some understanding of what the diagnosis is. We also often explain palliative care, what it is and what it's not, and we distinguish it from hospice care. We talk about physical aspects of care, making sure that symptoms are as optimized and controlled as possible. We talk about social aspects of care. Yes, that has to do with, are you married? Do you have children? But what we're really interested in is, who is your support system? Who's helping you get through all this? We ask about psychiatric and psychological aspects of care. We're interested in, are you anxious? Are you depressed? But also, how are you coping with what's going on? That's not only for our patients, but for our caregivers as well. We talk about spiritual aspects of care. Sometimes it has to do with religion or spirituality. Other times it just has to do with what gives you meaning. What gets you up every day? What gets you out of bed? What keeps you going? We talk about cultural aspects of care. what are the things that we should know to take the best possible care of you or your loved one? You know, are there specific rituals that we should know about? Are there specific cultural ideas that influence your wishes as you're going through a disease or even at the end of life? We focus on ethical and legal aspects of care. We want to know, do you have a healthcare surrogate form? Have you identified somebody to help you make medical decisions if you can't make them for yourself? And have you outlined what your wishes are specifically for end of life? Do you have a living will? Have you completed those documents? And when appropriate, we talk about care at the end of life. So I'll tell you, when I meet people in the clinic, I have some general things that I'm always thinking about. The disease itself, making sure that people understand the trajectory of the disease, making sure that people know with dementia, for instance, falls and hospitalizations and infections like pneumonia or urinary tract infections can cause a more precipitous decline. I want to talk a little bit about symptoms and mood and coping and some of those domains that I just focused on. But I also specifically want to talk about advanced care planning, the process of really thinking through what one's preferences are, what their wishes are for their care throughout the trajectory of disease. Because of course, we all know that by the nature of having dementia, people's cognition declines. And so we want to make sure that as early as we can start having these conversations so that the burden is not put on family members, but rather family members can really just honor the wishes of their loved one. We want to ask about caregiver support. We talk about that early and often, and it changes many times throughout the course of disease. We want to know about behavioral issues and how you're trying to compensate for some of those things at home. And then there's some tough things, of course, to talk about, how are things going at home? What's going to be the plan for when we need more assistance at home? Or do we need to start thinking about different living arrangements? So several years ago, a few of us were trying to figure out when should we really be initiating some of these, what we call serious illness conversations for people that have dementia. And we said, well, it could be routine. For instance, some of the patients that I see, every time they come back to see their neurologist, their primary neurologist, they also see me in the palliative care, neuro-supportive care clinic. And so just routine discussions, checking in with caregivers, making sure if there are medicines that they need for some of the symptoms, we can provide that, helping talk through some of the challenges, developing strategies for how to deal with some of the changes that are happening, or getting my other team members involved. In addition to having a physician as part of the palliative care team, we also have other physicians, advanced practice providers. We have a spiritual support provider. We have a social worker that works with us, a nurse that works with us. And so we have a whole team of people to really try to help with the needs of our patients and family members and caregivers. But for other patients, we think about events that should trigger some of these conversations. So when the wandering starts at nighttime, or when people are in and out of the hospital, or if there are concerns about the cognition becoming so poor that driving is no longer safe, we know those are challenging conversations. If there's increased strain on caregivers, or the symptoms seem to be increasing and quality of life is decreasing, sometimes that should trigger us to have some of these serious conversations. There's a decline in functional status, or decrease in nutrition and intake, or if people develop another medical condition like a stroke, heart disease, cancer. So I'll tell you that I remember very clearly being in Boston, Massachusetts in school. And my twin sister and I were in school together, and we would call home to Nashville to talk to our grandparents. And every time we would call, my grandmother would ask, "Where are you, baby? And what are you doing?" And we would tell her each time, as if it were the first time, that we were in Boston in medical school. And every time she'd heard it, she expressed as though she was hearing it for the first time, her excitement that her grandbabies were going to be doctors. We could tell from afar that she was deteriorating, but it wasn't until we got on a plane and went to Nashville to see her We found her in a nursing home. As we walked in, she was down at the end of the hallway with an aide feeding her. She looked nothing like she looked on our last trip home. She was far from that gushing grandmother, the avid championship bowler, the English teacher of 36 years, the Sunday school teacher. She was far from the woman that we remembered. And looking at her eyes, it was clear that we didn't look any more familiar to her either. By that time, she had advanced Alzheimer's disease and had just developed other medical conditions, including a stroke. And so as a family, we knew that it was time to have one of these serious conversations. How do we improve the quality of her life and really maximize it at that time? Well, we got palliative care involved. So I think about my grandfather and how much he tried to do to care for her at home before he ended up deciding that he needed more help, and she transitioned to the nursing home. We know, and I don't have to tell you all know this better than I do, about the toll that caregiving can take. We think about the daily needs and the assistance that you provide from sun up to sundown. We think about dealing with these repetitive questions. And we think about what we call anticipatory grief, grieving the loss that you know is coming. Some people are grieving, yes, the anticipated death, but many people are grieving the decline, the loss of the person that they knew, the loss of the things that they had imagined that you would be doing during that time in life, and the loss of the dreams that you had about what you were hoping to do. And how do we deal with that? And so our team helps people cope with that anticipatory grief as well. I take care of a lot of people who don't have neurologic conditions, but have other serious or advanced medical conditions. And caregivers of people that have neurologic conditions often have much more stress than other caregivers, because not only the physical functioning that's declining, but it's the cognitive function that's declining as well. So what do we know about the benefits of palliative care? We know that palliative care can improve symptoms. We know that palliative care can reduce unnecessary, but more importantly, unwanted hospitalizations. We know that palliative care can improve patient and family satisfaction, and it can decrease prolonged grief and post-traumatic stress disorder among family members. So in summary, I'll say palliative care is appropriate at any age and at any stage of the disease. Most palliative care is provided by primary care providers or the primary physician or team, neurologists, geriatricians, family medicine physicians, internists, but consultative palliative care may be available in complex situations and can be helpful. And overall, it can improve the care and quality of life for our patients and family members. This cartoon says, when I die, I want to go peacefully like my grandfather did, in his sleep, not screaming like the passengers in his car. And many patients will say to me, Dr. Robinson, that's just how I want it. I just want to close my eyes, go to sleep, and that's how I want it to be. One gentleman said, Dr. Robinson, I want to be at home, in my living room, in my recliner, with a beer in my hand, watching the Philadelphia Eagles when I go. And I said, I don't know if we can promise all of that, but what we can ensure is that we provide you the best quality of life until that time comes. Thank you.
Thank you so much, Dr. Robinson. What a great presentation. That was fantastic and so informative. So we're at the point now where we're going to start our panel. So if you have any questions for our panelists, for Dr. Robinson or for Doug Schilling, we also have Milva Ballister from the Alzheimer's Association. She presented yesterday. She's joining us again today. So if you have any questions for any of them with the presentations, or even just general questions while our experts are here, you are more than welcome to put them in the chat and we will answer them out loud. I did receive a few questions before today's presentation that I'd like to read out for a few people that were not able to join us today. So to start us out, I got a really great question from a gentleman who cares for his wife. And he says that right now his wife is only comfortable completing the more personal ADLs like the dressing and the bathing when asked to do so by a female caregiver. So he was asking, how can he make her more comfortable with starting and completing these more personal tasks when there is not a female caregiver? So Doug, Maisha, Milva, if you have any suggestions. Doug, you're on mute.
You know, that is a tough sort of situation. And I'm trying to understand how he phrased that. So wife is only comfortable when a female initiates the idea of her getting that kind of care.
Right. Mm-hmm. You know, something that I had thought about is you see it with a lot with dementia. You know, when I worked in memory care, there were residents that were uncomfortable doing these things you know, in front of the opposite gender, in front of somebody of a certain age, in front of somebody of a certain race.
Sure.
You're into those things, but what you want to do is not only make that person comfortable, but consider, you know, how can you create an association between yourself and the caregiver they are comfortable with? You know, and your staff in memory care facilities all wear the same colored scrubs. So they build sort of an association. Okay, purple scrubs is the caregiver that, you know, that's the person that cares for me.
Right.
Yeah, I was thinking about that idea too of making an association. And it is a very, very difficult situation, but maybe starting to involve individuals throughout the day that come along with that female provider and are able to do those things with them. That might help start developing a relationship at that point. And maybe also communicating that, hey, you know, so-and-so is here to help you. We're going to do it together. If you have questions, let us know. If you need help, let us know. And just starting to develop that relationship in that way.
Mm-hmm.
Yeah, and more often than not, what we tend to hear are the caregivers who are of the opposite sex of the person needing care, who are uncomfortable themselves. And certainly that needs to be sort of explored and find ways to help reassure and make the caregivers more comfortable with that. Because the reality is that person requiring the care is going to be able to pick up on in various ways the comfort level of the caregiver to provide that kind of personal care as well. And when they're anxious or uncomfortable or very worried about providing that kind of care, so that may be the farthest thing from that specific incident that you know gentleman was talking about, but there also may be a little bit of a component of that, and how we might be able to help him also be able to communicate to his loved one a greater level of comfort regarding those things himself.
Mm-hmm. Mm-hmm. Great thoughts. Thank you. We have a question in the chat. At what point should you consider asking about palliative care? Dr. Robinson?
So I think that there's a role for palliative care even at the time of diagnosis. I appreciate when I get a chance to see people soon after the diagnosis, because oftentimes I can still involve the person with memory loss and dementia in the conversation. When I see people very late in the course of disease, I'm mostly just meeting with the caregivers, and we're trying to piece together what we think their loved one would have wanted if he or she were able to be involved. And so I think for some of the things like the advanced care planning piece, it's great to have a meeting early on. And then as the needs increase over time, the role for palliative care can increase as well. And so oftentimes I'll meet people at the beginning, and then we may not meet again for 6 months or a year after that. But when the dementia becomes a bit more advanced, then we may start meeting every 3 months or every 6 months or so, depending on what the needs are. So I don't think it's too early ever to get palliative care involved. Remember, this is not hospice care.
Right. I think if we can help people make a connection in their head that what a chronic illness means is that they're going to have this illness for the rest of their lives. And that means at some level, they're going to have some symptoms. And forever, the idea of what they define as quality of life is going to be important. And so when you combine those things, so if they think, to themselves, at the point at which I get a chronic illness diagnosis or a serious illness diagnosis, thinking of palliative care as people who can take the time to really explore that in depth and educate us and help us talk about our wishes and our desires and plan for the future. I think that's the connection we want people to have in their head.
Mm-hmm.
Yeah, definitely completely agree. I think that this tends to be a topic that's not necessarily discussed during the care planning process. But it certainly should be. One of the things that we hear a lot from caregivers is, oh, I wish I would have known, what it is that they wanted, or I want to know how to best honor my loved one. And that's certainly something that can be done early in the process during the care planning process. So I completely agree. I think that it's never too early to discuss it. And I think there's an opportunity to do so in an honorable way with your loved one during that care planning process.
Thank you. A few more questions in the chat. A general dementia question: how can one reduce their risk of dementia? Are there any tips?
So it's a complex, I would say, group of factors that influence whether somebody gets dementia. And I'll tell you, we're not smart enough yet to know all the reasons why. Some of it we think has to do with genetic predisposition. Some of it has to do with lifestyle. And we try to encourage people, for instance, in our healthy brain tips, to do all the things that you have heard about many times to lower risk of many chronic sort of diseases. And so eating as well as you can. We often talk about the Mediterranean diet. So fish and lean meats and vegetables and whole grains, olives, things of that nature. We encourage people to get exercise in, about 150 minutes of brisk exercise a week. Obviously, we encourage people not to smoke and not to do behaviors that could increase risk of having other medical issues, which sometimes we talk a lot about Alzheimer's disease, but obviously you heard Doug also mention vascular dementia, and there are other types of dementia. So trying to lower your risk for strokes in the brain and heart attacks and other risk factors that can contribute to memory loss are important as well. But right now, we don't have a way to ensure that you can halt dementia or stop dementia or reverse dementia, but trying to live as healthy a life as possible can, we hope, try to reduce the risk of getting dementia.
Yeah, and there's certainly some research that is showing that socially interacting with others can potentially reduce your risk as well. And then also really challenging yourself, challenging your brain. So, if you enjoy doing puzzles, maybe go in a direction that challenges you a little bit more. If you enjoy reading, but maybe stick to a specific genre, maybe challenge yourself with a genre that may be a little bit more difficult for you. But yeah, there's certainly more research that needs to be done on that risk reduction aspect, but completely agree with Dr. Robinson. Just really living a healthy lifestyle is something to implement on a daily basis.
Thank you both. Doug, did you have anything to add?
No, I think they got it covered. Other than maybe simply a reminder, use your computer as much as you possibly can. The computer between your ears, challenge it, exercise it, push it, learn new things. Keep that computer exercising and working as much as you possibly can.
Thank you, Doug. I have another question kind of going back to the palliative care discussion. Does insurance coverage have a factor in a loved one being seen by palliative care during early onset of symptoms rather than later?
Oftentimes, palliative care is billed just like any other consult, cardiology, pulmonology, and neurology. And so insurance covers it usually the exact same way as they call. So it doesn't really matter when palliative care is consulted.
Good, thank you. Suggestions for getting more social interactions to lower the level of depression in the early stages of dementia.
So
Get involved in things. Certainly the last year we've all experienced has created challenges to social interaction, but we've also been really creative. Look at what we're doing today in terms of looking for other ways to do that. So even if we're more reliant on, long distance connections like this, or phone calls, or FaceTime, but getting involved in activities, groups, volunteering, or church organizational groups, anything that adds to our ways in which we can interact with anybody and everybody. It's going to be a plus in the big picture. As caregivers, doing interactive things with our loved ones, as opposed to simply doing things that keep them quiet and or are comfortable. Yeah, mom may really like sitting in front of the TV and watching TV, and enjoys that. But interactive things are not only going to help to potentially prolong their abilities, better, but the interactive human connection nature of things just really is, for most people, a better quality of life on top of it. And and we know how important anything social and connected with other people is in the big picture of things for quality of life. So those would be my thoughts.
yes, and I know yesterday we spoke a little bit about making a schedule or like some sort of agenda, like a daily calendar type thing that incorporates activities that you can do at home. So that's definitely something that you can do to incorporate social interactions, whether, we're definitely in a difficult time right now, but whether that's virtual or in a small gathering or with the church or, whichever way that looks to you as a caregiver, and in a way that still incorporates what your loved one enjoys doing. But, that agenda will definitely help and make it easier for you to be able to have those interactions on a daily basis, to have those activities at home on a daily basis. And again, you can alter that schedule if you need to. If something doesn't work, find something else that may work better. If something was really enjoyable, then maybe you can increase the amount of time to do it per week or however long they do it per day. So it's definitely something that you can alter, but it's helpful for you as a caregiver to have that in place.
Structure, yeah.
Mm-hmm. Thank you both. So we do have just a couple minutes left, but I would like to take some time to go through the rest of the questions that we have in the chat. For anyone that's joining us, if you have to leave, that's totally fine. The session is recorded, so we're going to be following up with that recording. But Doug and Maisha and Nilda, is it okay if we stay for just a few more minutes to finish up what we have in the chat?
Sure.
I totally understand.
I'm good.
All right. So we had a question about hearing loss. Is hearing loss going to increase as dementia gets worse? I think that's sort of a case by case.
It is a case by case, but in general, not unusual for that to be the case, given that it's not unusual for the sensory area of our brain to be being affected by the progression of the disease. And although I'm really more inclined to leave this in Dr. Robinson's hands, certainly our experience over time with the progression of the disease in our patients, not unusual at all for us to see hearing problems increase, as well as visual problems and other sensory kind of deficits. Doc, what do you think?
It's often challenging to know whether there's a problem with the hearing or a problem with the interpretation of what people are saying. But I completely agree with you. I think making sure that people can hear well is helpful, because sometimes we can compound the problem of memory loss if the hearing is problematic. And so we assume people are understanding what we're saying, but it's really just they can't hear us well. And so if people can get some sort of compensatory aids like hearing aids to try to help, that can always be, I agree, helpful to increase and optimize the cognitive status.
And using,
I
I think it's great to get it sort of used to the idea at any point that we're going to start using pictures and words, notes written, regardless of whether we think what's going on is that they're not hearing well or they're not understanding, because those things can help in either case.
Wonderful, thank you. So Dr. Robinson had to hop off for an 11 meeting, but we just have a couple of questions left. I'm just going to finish these up. So we had a question. She said, I'm a caregiver for my mother who has dementia and I'm finding very little support for respite. Does palliative care address these types of needs with recommendations?
Well, certainly looking from my standpoint, looking at how having opportunities to get a bit of a break from caregiving and the stresses of caregiving can be a part of what palliative care can make sure loved ones, caregivers, family members are looking at, thinking about, planning for, trying to figure out how to do. Since hospice care is a component of palliative care, a subset of palliative care, designed specifically for those folks who have a prognosis of 6 months or less, I will let you know or remind people that a part of the hospice benefit that is provided is a respite care component. So that if somebody is a hospice patient, one of the things that is built in is the opportunity to get up to 5 days at a time of respite, where the loved one is placed in a safe a long-term care facility or one of our inpatient units, and provided that care to give caregivers a break and to acknowledge the fact that being a caregiver, especially with a dementia patient, can be an overwhelming and exhausting thing. But certainly non-hospice palliative care can be a part of helping caregivers think about, plan for, expect, come up with alternatives and ways that they may supplement the caregiving that they're providing, whether it's by hiring a professional caregiver sometimes once in a while, other family members working those things out. One of the roles of palliative care is help people know what's coming and what they should be thinking about and planning for. So that component they certainly are going to be a part of.
Thank you so much. So we had one last question here. Any guides for creating memory care activities that this caregiver can share with the in-home support caregiver? So anywhere they can look for activities that they can share that their loved one can do in the home with an in-home caregiver?
Sure. And one of the handouts that I sent, just so everybody knows, to Candace is kind of a model of a memory aids worksheet that I think, let me ask, Candace, would you be able to make available to people by emailing them in addition to the presentation, that other little handout that I sent you?
Absolutely.
Okay, good. And the tips that really I think are the most important regarding this are have it be as interactive as possible, have it have as many different sensory components as possible. So don't forget about things like music and visual stuff. Build in things about with other senses. if your loved one is not able to tell you this themselves, find out from somebody what their favorite food was when they were a child. And maybe it's Necco wafers candy that was popular a million years ago, and they haven't had them they haven't had one of those in 40 years. But because it represents something that's a connection to the memory that they do have, that's gonna stimulate their memory in a taste way. Our memory can be stimulated by smells. We have very powerful memories regarding smells. Think about all the different senses that we have that you can make part of a memory aid activity of any kind. So, sounds, smells, tastes, touch, as well as seeing things. And so try to include all of those kind of things in whatever little ways you can. Again, be cognizant of where their memory components are at this point, and try to focus in on those kinds of things. And to whatever extent they can also be involved in hands-on things like the gluing or pasting or cutting out of pictures, so that they're using their motor activity part of their brain as well, and giving that a chance to and they're going to mess things up, and they're going to have a hard time doing it. And so the important component of that is sort of the reassurance and it's okay, we can do this again. Let's, so that it doesn't end up being a frustrating experience to them, even when things don't go exactly as planned. We have to look for ways to have it be, bottom line, a positive experience regardless of how it goes. And if it's going badly, or if something happens that causes a negative emotional reaction, it's okay to stop, distract, do something else, move on to something else, learn from that, and come back to it at another point. A lot of what we're doing and figuring out as we're caring for people, in particular with dementia, is a little bit of trial and error. This worked great. This didn't work great. This worked great on Monday and was not such a good idea on Wednesday. That's the reality that we all experience with this. Mom knew who I was and what we were doing, and everything was cool on Wednesday, and on Friday afternoon, it was a completely different story. That's the sort of frustrating, exhausting, stressful reality of dementia. And you got to give yourself permission that that's okay. That's my point of view.
And to close this out, Milva, are there any resources on the Alzheimer's Association website of lists of activities or anything?
Yes,
that maybe
that's exactly what I was going to say. We have a couple of different pages that goes over activities you can do at home, but I will go ahead and just send you the PDF version of that, Candace. It has like 100+ activities that you can really make your own. That's the beauty about it, is you can make it your own, and you can utilize what your loved one enjoys doing to make that something that works for both you as a caregiver and for your loved one. So I'll send that over to you. I think it's a really great resource, but absolutely the Alzheimer's Association, the website has some strategies and some ideas that you can find on there.
Wonderful, thank you. And just a reminder to everybody, we're going to be sharing the recording and the information we've talked about and these handouts via email. I will probably send those out at the beginning of next week once I get everything edited and put together. So we'll have those available for you. So it's been a really great discussion. I know we've gone over time, but I appreciate you both staying with us, and I appreciate everyone that's stuck around. But I'm going to go ahead and wrap us up. So really quickly, we're at the point where I like to send out a short poll just to get feedback from everybody that's joining us. I'm going to go ahead and launch that right now. This is a short 5-question poll. It should go really quickly, and it really helps us be able to improve these sessions in the future and know, what worked and what might not have worked so well and what you'd like to see more of in the future. So I'm going to leave that up for you all to fill out. And while you do that, I'm just going to, like I said, close this out. So thank you so much for tuning in this morning. Like I said, we're following up with an email beginning of next week that's going to have the recording and any additional materials that we talked about today. So make sure that you're keeping in touch with us by subscribing to our Caring Together newsletter. That way we can send out details and registration information for future events and any other new resources. You can also like us on Facebook and you'll see our updates on your news feed. So if you wind up having any other questions, comments, concerns, you can reach out to me at info@caregivercoalition.org or reach out to our website, which is caregivercoalition.org, and fill out that little questions or comments form at the bottom of the page. So with all that being said, thank you again for joining us. Doug, thank you so much for being with us this morning. Milva, thank you.
Take care, everybody.
Information.
Thank you.
Thank you, everybody.
Thank you. Have a great day.
Thanks.